Thank you, operator, and thank you to everyone for joining us for the COVID-19 daily media call for May 26th. Governor Walz is not on today's call. We'll start with the situation report and updates from Commissioner Jan Malcolm. Following Commissioner Malcolm, we'll get an update from Infectious Disease Division Director Chris EHRESMANN. After those updates, we'll open up for questions from reporters on the line. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. I will begin, as usual, with the global and national update, and then talk about Minnesota cases kind of over the long holiday weekend just concluded. Around the world, as of early this morning, more than 5.5 million cases and 346,000 deaths have been reported from COVID-19. In the United States, as of this morning, 1.6 million cases and more than 98,000 deaths have been reported. Here in Minnesota, we are at a new total of 21,960 laboratory confirmed cases. There were an additional 2,117 cases reported over the long weekend. Yesterday's addition was 650. We are continuing to do well by the metric of case doubling time. We've talked about that on prior calls. We are looking for at least nothing shorter than a 7-day doubling time to give us sort of an indicator of how fast the epidemic is growing. We are now at 16 days to double, which is lengthening a little bit over the last couple of weeks. The median age of cases is 42 years old. I know that there's a common perception that this is an illness that only affects the elderly, but that is certainly not the case. While the elderly and people with underlying health conditions are at significantly higher risk for severe disease, it's important to note that our median age of cases is 42 years old. 17% of all cases are people in their 20s, and 20% are between the ages of 30 and 39. We are unfortunately at a new total of 899 deaths in Minnesota. That's 47 Minnesotans having passed away from COVID-19 over the holiday weekend. 18 of those deaths were reported yesterday. Of the 18, 10 were in Hennepin County, 3 in Dakota, 1 each in Chippewa, Clay, Goodhue, Nicollet, and Ramsey. This total includes 1 person above the age of 100, 7 in their 90s, 5 in their 80s, 1 in their 70s, 3 in their 60s, and 1 person in their 40s. Again, just reinforcing the fact that while risk is certainly elevated for the elderly and those with underlying health conditions, and especially the combination of the two, we do see severe disease and even death among younger people, and occasionally some without any known pre-existing conditions. So this remains a great concern to the overall community in Minnesota. 15 of yesterday's 18 deaths occurred among residents of long-term care facilities. From a hospitalization standpoint, there are currently 570 patients in the hospital, 258 of those in long-term care. And if you look at the data over the long holiday weekend, you see some fluctuation up and down in terms of numbers of people in the hospital. Some days with significant increases, other days with decreases. But hospitalization in the ICU units has continued and has increased by a pretty significant degree. And I think Chris EHRESMANN is going to speak to that a little bit more in just a moment. In terms of some additional information to share with you today, our testing volume continues to grow quite nicely. We had even almost over 5,800 cases or tests rather produced by all the labs reporting yesterday on the holiday Monday, which is quite a large number for that day. Mondays and Tuesdays, as you probably recall, tend to be the lowest numbers, but over that long holiday weekend, we saw over almost 8,500 tests on Friday, over 6,000 on Saturday, and over 5,800 on, I should have said 8,400 on Saturday, almost 6,100 on Sunday, and over 5,800 on Monday. So really strong laboratory data from the long weekend. And as you recall, a significant part of that was the free testing that was opened up at 6 National Guard Armory locations across the state throughout the holiday weekend. And we are just extremely grateful to the Guard for their extraordinary work in helping to set those up with very short notice and staffing them. It was an incredibly busy weekend. The Guard provided very close to 10,000 site tests at these 6 sites. We had been thinking that the goal could be as high as 6,600. That's what we had sort of planned for on the top end. So the fact that what actually happened was 150% of that goal, that is really something. And a lot of people scrambled to get more supplies to the testing sites, and it was very clear to us that the turnout, the public turnout at these sites, really does make it clear that there is a great interest in testing and a need for methods of getting testing out to the public in ways that make it accessible and easy for them to get to. We don't yet have a lot of data of the results of this testing, but in addition to testing symptomatic people, this was a no barrier kind of testing pilot, if you will, where even people without symptoms were given tests, and we thought that would be one way of getting some kind of really preliminary kind of surveillance testing of a sort to help us get a picture of where there might be greater and lesser concentrations of positivity rates among these 6 sites. Chris might have more comment there as well. So this was clearly a very, very successful initiative, and came with a lot of really hard work from the Guard and others. So we're going to harvest the lessons learned, see what data this provides to us, and we'll be communicating in the coming days about how it is that we intend to do more of this kind of mobile community-based testing around the state. I'd also like to comment on a couple of things that came up in questions last week. There was a question about whether Minnesota's health plans would be extending the agreement that they had previously reached with the Departments of Commerce and Health to waive copays. That they had been required by federal law, as you may recall, to cover testing without cost sharing, but they had also agreed to waive copays for COVID hospitalizations, which originally was to expire on June 1st. The health plans have, nearly all of the health plans have agreed to extend waiving those copays through September 30th. Another piece of news to share for today, the health department is announcing today, I believe that this is just going up on our website now, that we've awarded $97.6 million in emergency healthcare grants to nearly 360 provider organizations across Minnesota to support their preparation and response to the COVID-19 pandemic. These healthcare response grantees include a wide range of healthcare providers, from primary care clinics and long-term care facilities to hospitals and health systems and first responders. So about half of the funds went to this variety of organizations for additional staffing costs, with the next largest share of the funds going for supplies, including for their purchase of personal protective equipment, which, as you might recall, has continued to be an important strategy. In addition to the state's PPE reserves, we have encouraged providers to be using their usual supply chains to get whatever supplies they can get through their typical supply chains. And so some of this money is to assist them with those costs. In addition, providers can use this grant money to establish temporary sites to provide testing or treatment services to expand the number of beds available for COVID-19 treatment, to isolate affected patients or staff, and to support emergency transportation. Grants can also fund some temporary information technology support to support triage screening and telemedicine, which we have seen growing very significantly with this pandemic. With this round of funding, we prioritized funding assisted living facilities, healthcare systems, hospitals, emergency medical transport, and primary care clinics. The goal is to support these providers with caring for COVID-19 patients and for preparing for the ongoing rise in cases that we are still seeing and expect to continue to see increasing in the coming weeks. We also prioritized funding smaller providers, both in the metro and in greater Minnesota, in recognition of the fact that some of the larger systems also are benefiting from federal funding. We have notified all of the providers who've been awarded grants, and you can see the full list of grantees on the MDH website. There is a healthcare response grant page there on the MDH web. In addition to the grants that we're just announcing today, there are some funds left in this fund. In March, the legislature passed an appropriation authorizing $200 million in state funds to invest in this grant program. And there is still some money left in this fund, and we have set this up to have the money kind of be granted in waves, if you will, to allow for our ability to fund some needs that might emerge later in the pandemic's evolution here in Minnesota. And this application process is an ongoing one. The application process remains open and will until all funds have been spent. We do encourage organizations to submit their applications as soon as they have identified a need and as soon as they can. We do kind of package them up and make some award decisions as we have today in waves. So there will be further grant awards announced in coming weeks as well. We just, again, want to thank the legislature for their proactive action in making this funding for healthcare providers, including long-term care, available for us to work with our communities around the state. This, what I've just talked about, is really the second type of COVID-19 emergency grant funding that the legislature authorized. The first $50 million under a different grant fund, the short-term emergency fund, was awarded back in early April, on April 8th, to about 350 provider organizations around the state. So the legislature's support for these efforts has been critical to help providers all around Minnesota, and we're very grateful for that. With that, I will turn it over to Kris EHRESMANN. Thanks, Kris.
Thank you, Commissioner. Over the weekend, we saw a jump in ICU bed use, and I'd like to provide a bit of context for that. We had our largest single-day increase of 41 for COVID-specific ICU bed use from Sunday to Monday. The next highest one-day increase was 25 back on May 16th. We're also hearing of hospitals that were at or near ICU capacity at the end of last week. In addition, we have heard of isolated staffing concerns. This level of ICU use has not been unexpected. We track COVID-specific admissions as well as overall hospital, medical, surgical, ICU, and ventilator availability. This past weekend, the overall picture for ICU bed availability on May 25th showed 87% of the ICU beds in the metro were in use. Other regions of the state had more availability. For comparison, it isn't unusual for ICU beds to be 95% full during flu season. That said, we are keeping a close eye on this, and we are in regular contact with hospital leadership to address issues as they arise. And with that, I will turn things back over to Mike Schomer.
Thank you, Chris. We'll open it up for questions now. As always, we ask that reporters limit their questions to one primary and one follow-up so we can get to as many as possible. With that, operator, we're ready to take questions.
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. Again, that is star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. We have our first question coming from the line of David Ulrich with Pioneer Press. Your line is open.
Hi, thank you. We've just finished the Memorial Day weekend, and I want to talk just a little bit about the University of Minnesota model because this cuts to the heart of people's confidence in you guys and Governor Walz, because this is an important model. The last projections that were a couple of weeks ago suggested that the case number, the deaths could more than double by Memorial Day, and I'll spare all the numbers, but suffice it to say that we are not anywhere near on track with the 1,400 to 2,000 deaths by the end of May that that was the range that model had predicted. And I'm wondering if one of you guys can talk about that.
Sure. I think, that's a perfectly reasonable question. And as we have said from the beginning, the model is one input, one set of data that we look at, but it is far from the only one. And I think we've said it is broadly directional, not intended to be specific with its projections about numbers, either numbers of cases or numbers of deaths or specific dates, but with very broad ranges. That said, it is certainly the case that the projections are in the model. The scenarios that the model looks at are so far our actual experience is more favorable or more conservative than that. And so I think that is why periodically, you might remember the university team and Stefan Gildemeister talking about fitting the curve to actual data. And each time they do that, it narrows the range of future model, the range around the different projections. So I think it's perfectly fair. And to be honest, I think most of the models out there have seen, fairly large-scale corrections, if you will, in one direction or another. The IHME model has gone the other direction. Their projections have become less optimistic as time has gone on, and many of the other models, including some of the data that we know others are using here in Minnesota, have become relatively more optimistic. So that's just a very long-winded way of saying I think this is not unexpected, and it's good news that we'd certainly rather have the model be not overly optimistic, but get more precise as time goes on with more Minnesota data. But again, I just would reinforce people shouldn't think that the model is what is determining the governor's policy decisions, because it's really not. What it did in the beginning was clearly help us understand and quantify the degree to which more ICU capacity was important for minimizing mortality and long-term negative health outcomes. And so that's where we put a lot of focus, and I think that's where the model can be useful, is pointing out what are the things that most influence these broad directional outcomes so that we can work on those.
Just very quickly, closer related, since we've gone the other way, our doubling rate keeps slowing. Do you worry that there's a growing sense out there that all of this coronavirus stuff is just simply a little overblown?
I think that is something that we've talked about early on, and we continue to talk about and be very, very aware of, is that particularly perhaps among people who don't know anyone yet, and I stress yet, who's been directly personally affected by COVID or had a severe bout of illness, or even have lost loved ones to this disease, folks might think, well, this is only a problem in air quotes for certain populations, but not for me, and that's just not the case. We've talked a lot about the role of the degree of community spread that we have around the state, that a lot of people, and what we've learned since the beginning of the epidemic about the role of asymptomatic spreading, that some of us may actually be carrying the virus, not have either very subtle symptoms or no symptoms at all, but still be capable of spreading the virus, and we are spreading the virus to healthcare workers who then are taking it into healthcare settings or others. The food processing plant outbreaks that we've seen in now 9 counties, might be 10. Chris can comment on that. Those too are having an impact on community spread, not in those counties, as people move around the state, and workers may work in one community during the week and go home to their families over the weekend. And we do believe, and again, Chris can say more about this, that all of these things that we think are isolated cases actually are driving community spread as well.
Thank you.
We have our next question from Theodore Keith with Fox 9 News. Your line is open.
Hi, Commissioner. Today we have 2 of the state's 4 biggest cities, Minneapolis and Bloomington, releasing guidance on how their restaurants can expand into parking lots, sidewalks, and other spaces to do this outdoor dining on June 1st. As these restaurant owners are renting their tables and chairs and tents and planning live music, they might be wondering, gosh, how long is this going to go on? How long are we going to have this set up outside and not inside? What is your guidance to them as far as what they should be thinking?
Well, I think when the governor talked about the next stages beyond June 1st, he didn't set dates for a reason, because we consider that we're in a pretty volatile phase in the curve, we think, with these numbers going up and down and hospital capacity seeming to beginning to accelerate. We really feel we need to keep a very close eye on the data. We also need to do a better job, I think, of helping people understand that it takes, probably 14 days plus, 14 to 21 days for something that is already in the pipeline to show up in healthcare utilization data or confirmed tests. So we won't know for a bit yet what are the results of the policy changes that have or the guidance changes that have already been made, both through executive order and the guidance. So I know that's not a satisfying answer. People would like to know a date certain, and honestly, I think we would be doing a disservice to give a date certain and then either have to proceed despite any warning signs. We've talked about the dial back criteria, that we're going to be monitoring really closely. So I think one thing that we don't want to do is say, no matter what those indicators say, we're going ahead on X date because we said we would. That said, we totally understand that people need something to plan toward. So that's why the folks continue to work on guidance for kind of best practice protocols that need to be in place when we do go to those next phases. And I just understand how frustrating that is, but I think we need to see, what the data reveals about the impact, especially on community spread and hospital capacity of the things that we've done more recently.
May I just ask, Commissioner, on June 1st, will you be planning to eat in a restaurant parking lot or on a restaurant sidewalk?
That's a great question. And, yes, I absolutely will be comfortable doing that, especially if and I will be sure to know and sure to ask what the practices are that the restaurant has in place. If the distancing is clearly right and the maximum capacity is manageable and folks are wearing masks and my companions are wearing masks, then yes, I would. Is there a next question?
Moving on to the next question, we have Steve Karnowski with Associated Press. Your line is open.
Yeah, hi. I just wanted to circle back to, we had some discussion on Friday, but back to what Dr. Birx had to say in last Friday's White House task force briefing. She was saying that Minneapolis ranked 4th in terms of positivity among major metro areas, behind only the D.C. metro area, Baltimore, and Chicago. She put up a slide showing Minneapolis with about a 13% positive rate on a 7-day average and about a 19% 30-day average. I'm still trying to figure out what's behind the city's higher positivity rates. Is it a function of who we've prioritized for testing, or does it have something to do with the cluster in the Cedar Riverside neighborhood, perhaps?
I'm going to ask Krista to comment on this as well, but we do think, I think as we said on Friday, and we've had a direct conversation with Dr. Birx as well, and we kind of traded perspectives with her. It is important to know that how much our testing has ramped up in recent weeks, and the fact that we are aggressively testing long-term care facilities, aggressively testing in the sites of those food processing plant outbreaks. And as I mentioned, and Chris may want to say more about this, we don't believe that the cases that are associated with the counties and with those specific plants remain only an issue for those local counties, but do in fact contribute to community spread in other communities. Chris, can you say more?
Sure. What I'll add is that, as the commissioner mentioned, we just this weekend was really an expanded opportunity for testing, but up until this point, our testing has really focused in settings in which we expect to see a very, very high positivity rate, and the number of those settings have been in Hennepin County because many of the long-term care facilities where testing has occurred have been in Hennepin County and Minneapolis. Additionally, as the commissioner mentioned, for some of the plants where we've done testing, some of those individuals may go home, and home being the cities on the weekend, and so that may also have contributed. So I think that we could expect that as testing expands and as we're able to do testing outside of very high risk and high predictability settings where we expect to see a lot of positives, we may see that number go down. But right now we are sampling in places that we know that we will have very, very high levels of positives. And as I said, many of those are in that geographic area or in individuals who return to that geographic area as their home base.
So, I mean, the numbers that you put out there, are they significant then? Are they telling us much about how it's spreading here in Minnesota?
I do think that it's significant in that we recognize the connectedness of so many of the things that we're looking at, where individuals who work, say, in one location may have relatives that work in another location, and you see connections between multiple places. So we're taking it seriously, but we're not surprised, I guess is the way I'd explain it. So we're taking it seriously, but it's not a surprise to us or a shock that this would have happened. It makes sense based on how we're seeing cases play out.
Thank you.
We have our next question coming from the line of Jeremy Olson with Star Tribune. Your line is open.
Hi, I just wanted to ask about staffing levels for hospitals and actually for nursing homes when it comes to nursing staff or caregiving staff in general. I mean, as you'd mentioned, hospital ICU bed levels are increasing. There may be a need to use some of these extra beds that can be available within 72 hours. I guess I'm wondering, how confident are you that we have nurses to staff those beds if we need them? Do they really exist, or is it just on paper? And same with the long-term care facilities, as you anticipate some people being out of work. Do we have the people to get done on paper what we need to get done?
This is Commissioner Malcolm. Yeah, those are great questions, and I can say that the surge capacity numbers that we've been reporting and that the health systems report are staffed beds. So it's not just theoretical, but it's beds that have critical care staffing available to them. Now, if we have lots of staff who are out ill themselves, then yes, that could have an impact on the surge capacity numbers, which is why I think it's such a high priority that the healthcare workforce is protected and prioritized for things like testing and for personal protective equipment. There's a lot of demand for supplies, and we've always said, that the medical grade personal protective equipment really has to be used for actual care providers, and that other types of masks and gowns are appropriate for those of us who are not hands-on caregivers. So long-winded way of saying, we totally recognize the critical importance of the workforce being available to staff those beds, and yes, those numbers do take into account staffing. So if staffing should change, the numbers of available beds will also change. Long-term care staffing. Oh, go ahead, Chris. Do you want to jump in?
Oh, I was just going to say that one thing that I failed to mention in my comments was that last week the Critical Care Coordination Center was activated, and so representatives from the SEOC and each tertiary care hospital meet daily to identify concerns and discuss how to maximize capacity. So that is also a forum where staffing is discussed and planned for.
Good, great, thanks, Chris. The long-term care staffing that's a real conundrum, and we've talked about that. That the staffing challenges in long-term care long predate the pandemic, and the pandemic has certainly exacerbated it. And that's why we're doing what we can to line up, willing volunteers who can do some of the functions that are needed in those facilities. We've got, as we mentioned last week, some support from through the Federal Emergency Management Agency for surge staffing for long-term care, which is very, very welcome. But we're obviously going to need and are working closely with the health systems to see what surge staffing they can provide in long-term care. Now, fully understanding that may not be available as we get further toward our peak. But we have to figure out how to use all the tools in the toolbox to create incentives for people to do this work, and we've been grateful for the legislature's support of reimbursement increases for skilled nursing facilities and assisted living. That helps. But just the availability of people is really critical. So we think that building up that ability to match available staff with where the need is has been a real priority, and we do have systems in place now that make it easier to match resources to facilities that need them. But I won't, for a minute, underestimate the fact that this is a significant and ongoing challenge.
Chris, can you elaborate on the opening of the Critical Care Coordinating Center? Was that just going to happen that date at random, or did it happen in response to something?
It's happening as part of the expanded ability to respond, but it wasn't that there was a crisis necessarily on a given day. So it was planful, but not based on a crisis situation.
Okay. Thank you.
We have our next question coming from the line of Kent Erdl with KARE 11. Your line is open.
Jan, you mentioned that of the 10,000 tests at the 6 sites that through the National Guard testing this weekend, many people came without symptoms to simply get a test. And I was just wondering, with asymptomatic spread being such a topic of conversation with the CDC, and obviously just the curiosity here in Minnesota, how do you plan to use that data or maybe break it out? Is that being tracked? Do we know how many people without symptoms of those 10,000 were tested?
Great question, and certainly that this isn't a formal surveillance test because it was put together really quickly, and but absolutely we think as an initial indicator or as a way of seeing what happens when you invite asymptomatic people. Yes, we tried it on the front end to collect the data, and do have that data, who was symptomatic versus asymptomatic. So we will have some data out of this. I just would want to say, I'm sure Ruth would say, were she on the phone, and Chris may have comment on this too, that it wasn't kind of a rigorously designed surveillance testing strategy, but it's a real world, real life reflection of the interest in testing, and particularly the demand among asymptomatic people who, for one reason or another, had not been accessing testing through the healthcare system sites that have been up and available, but that we do think that it will yield some valuable data. I'm not going to say it's going to be definitive, but it will help. It will help further inform our estimates of how much asymptomatic spread there is. Chris, anything more you'd add?
Yeah, we'll be looking at these data as we get the positive results, and as we interview people, it will be an opportunity to identify, what symptoms they may or may not have had. But at this point, we don't have that in a data set that we can access immediately, so cannot comment and give you more answers to your question.
Okay. I was also wanting to know the status of the testing at long-term care facilities right now. I've been reached out to by some asking about if they maybe have loved ones that still haven't been tested yet. Why are they testing at 6 sites around the state when this has been said to be a priority? Can you give us an update on where that testing effort is at?
At this point, we have 7 sites that were being, I believe, tested today. The reason that the testing was offered outside of long-term care over the weekend is that there's a lot of planning. Testing alone is not the answer to anything. Testing needs to be part of a comprehensive plan for response, and particularly so when you are looking at congregate care or congregate living setting. So many facilities have signed up to have testing done, but they felt that given the holiday weekend and the need for planning, that they would not be able to do the important planning work that's needed so that when they get the results back, they can take the appropriate action. So we had deferrals on testing in long-term care facilities, and that's part of the reason that the opportunity was taken to test in another population. So we are now continuing to do testing this week, and by we, it's the absolute royal we of the system. That testing is continuing this week.
Is there a number of that you'd be able to provide us of those that are still awaiting tests, or a percentage of where we're at, just so that we have an understanding of how far along that process is?
Well, I could. Oh, go ahead, Jen.
No, I was just going to say we're working on building a dashboard for exactly that purpose, so that we can be more clear about where we are against not only the testing goal, but the other goals related to the 5-point plan, because we certainly recognize the critical nature of that work and the high degree of interest in it. So we're trying to build out our data so that we can better answer that question. Chris may have a general sense of it, but I don't have a precise number that I can give you.
Well, I was just going to add on that, we are very early in the process, because obviously there are hundreds of types of facilities for which where testing could occur. But I think one thing to keep in mind is, just as I was explaining that testing alone is not the answer to anything, it needs to be accompanied with other, infection prevention and cohorting and some of these other actions. The other thing is that our recommendations for testing in long-term care, when you're doing this type of testing where you're testing everyone, staff and residents, the recommendation is you do a baseline, which is the first time that a facility is tested, and then you do a follow-up at 7 and 14 days. And so because of that, as we're working through the system, it takes a while to accomplish all of that testing. Although, we are aware that there are contracts that are out that are being developed to increase that testing capacity. So it is going to be increased, but keep in mind that when a facility is tested, it's tested at baseline at 7 and 14 days. So it does involve multiple testing instances.
Operator, we have time for one more question.
We have our next question from Kate Raddatz with WCCO TV. Your line is open.
Thank you, Commissioner. You mentioned that this increase in the ICU capacity was not unexpected, but looking at that 87% number, you said in the Metro yesterday, is that concerning, knowing we'll soon be loosening restrictions in terms of how close are we going to get to being at or over capacity?
It's a great question. I think Chris's point was that it's not unusual for systems to run, close to that level and to adjust accordingly. Now we've got some precision around how much surge capacity is possible around the system, and mechanisms in place to try to support taking a really system-wide approach to this and helping to place patients where there is available care on an immediate basis. I will make one comment that certainly one of the things that has affected the increase in ICU use was the resumption of services that had been deferred. I had said a couple times that if I could, roll back time, I would, not have had us use the word elective procedures when talking about the original executive order, which I think in the language of the order was perfectly clear that the things to be deferred were things that were, not critically medically necessary. But the reality was that we were being extremely cautious, and health systems were being extremely cautious about deferring procedures that were not, imminently urgent, but very important, very medically important. And so we do know that since that authorization for a more expanded set of procedures was put in place with guidance about what that meant in terms of facilities needing to be assuring different things about the safety for patients and staff and so forth, and with an eye toward having, retaining enough PPE to be ready for increases in COVID cases. But what we've seen and heard about the, deferred, really important procedures being done is part of what's showing up in the ICU numbers as well after complex surgeries, cardiac, neurological, oncological. Really important surgeries have been happening, and that's driving some ICU use too. And that's a good thing to catch up on some of that. So what I've heard from some of the clinical leadership is that they expect to sort of see this pattern of ICU numbers coming up, as a result of some of the really, hard work to get a lot of deferred cases cleared up and caught up with current volume, and then those numbers will normalize. So we will be keeping a really close eye, and as Chris mentioned, the daily consultation among the systems and with our statewide healthcare coordinating center is the way that we will keep an even closer eye on this going forward.
Thank you. And just to follow up to that, the governor had mentioned, back in March that at one point stadiums were even being considered, as a kind of a makeshift ICU area. Is that something that's still on the table as we get closer to the peak?
Thanks for that. That is something that we've learned from other communities was not a particularly effective strategy. It's certainly not optimal in terms of clinical care. We want to keep the care as close to hospital settings as possible. The alternative care sites that have been vetted and the one that will be opening or ready, won't be open to patients necessarily until that's needed, but those alternative care sites, I think we've taken the approach of identifying where they would be and getting all the plans in place to be able to stand those up in like 72 hours if needed. So that's our approach rather than large open spaces. I won't say it's impossible that we would turn to something like that, and certainly we've seen other communities do it, but they've really not been used very much. And from a clinical perspective, that would be sort of the last resort.
That is all the time we have. It's all the time we have for today's call. I want to thank our speakers and the reporters on the line. If you had a question we were not able to get to during the call, please feel free to reach out to our office. Have a good day, and we will talk again soon.
Find more local news stories at ccxmedia.org and follow us on social media.